So again, I would like to welcome everyone to the IRDEX webinar. Thank you so much for joining us from around the world. This is the easiest job in the world to bring together experts in this space to discuss their techniques and their expertise with treating a plethora of retinopathy and disease. It's my absolute pleasure to have Dr. Shawn Kavoussi and Dr. Roger Goldberg join me, and I'm looking forward to learning from them as much as from myself. So I'd like to thank the panelists for joining us today. So we are speaking today about how MicroPulse therapy can help reduce the treatment burden that we see in our patients. And we know that the burden of success is quite strong. These medications work extremely well, whether it's anti-VEGF or steroid therapy, but you really do require a lot of treatment to get there. And as we know, many of our patients have a lot of difficulty making it back to the office. And now we have a COVID pandemic to deal with as well, which further increases the burden of coming into the office to see us. So is there another option for us? So these are my relevant financial disclosures. I'd like to just introduce the panelists. Again, I'm Caesar Luo. I am a partner at Bay Area Retina Associates up here in Northern California. I did my residency at Wills Eye Hospital in Philadelphia, and then did my fellowship at William Beaumont Hospital, Associated Retinal Consultants. I have been out here now for the last 4 years, and it's been my absolute pleasure being able to work with such great physicians like Dr. Roger Goldberg, who is joining us today on the panel. Dr. Goldberg is a vitreoretinal surgeon and partner at Bay Area Retina Associates. He graduated from both college and medical school from Yale University, and then completed his residency at the world-renowned Bascom Palmer Eye Institute. He did his vitreoretinal fellowship at Tufts and Ophthalmic Consultants of Boston. He's been very active in clinical trials as an investigator in over 30 clinical trials for age-related macular degeneration, retinal vein occlusion, diabetic retinopathy, and others. In addition to his medical training, he did receive his MBA from Yale as well, and he worked as a healthcare consultant at McKinsey, and then co-founded an ophthalmic startup as well. We then also have the pleasure of Dr. Shawn Kavoussi joining us as well from Texas Retina Center. He completed a Rice-Baylor combined BA-MD program, and then did his ophthalmology residency also at Yale, followed by his vitreoretinal surgery fellowship at Baylor. He's been practicing since in Houston and has recently founded a solo retina practice, which I'm very interested to discuss further with him, at the Texas Retina Center, at the largest largest medical center in the country. So again, thank you so much, Dr. Goldberg and Dr. Kavoussi, for joining me here today. So let's talk a little bit about MicroPulse. What exactly is it? It's a continuous wave pulse, but it's chopped into very small little micropulses with a small shutter that makes sure that you don't get one continuous burn. Because of that, you get a lower energy per pulse, and then it allows for tissue cooling between the pulses, as you can see on the graph on the right. So with a 15% duty cycle, you do get a slight increase in the temperature of the retina, but with a low duty cycle of 5%, you do allow that retina to cool down between each pulse. Now, if you try and just decrease the power of continuous wave, that is actually not equivalent to a MicroPulse therapy. You do get less tissue heating than just turning down the power. So a few things I wanted to talk with everyone today. I do believe that there is a learning curve with MicroPulse. So when I was first starting using this technology, what I did is I actually gathered my first 100 eyes that I treated with diabetic macular edema and the use of MicroPulse technology. So we found in the total study group of those 100 eyes, there was a statistically significant improvement in the central foveal thickness, But this is what was interesting. What I did was I actually broke up the first half of the eyes versus the second half of the eyes. And I found that the second half actually had much better results. And I think a lot of that does have to do with comfort and technique. And we'll talk a little bit about that as well. Also, something I found in my sub-analysis was that pigmentation seemed to matter. So patients who were listed as Caucasian in our electronic medical records had less eminent improvement than patients who are listed as non-Caucasian. And I do think that's probably secondary to the next slide. We used 532 nanometer laser. So 532 nanometer laser is a very widely used laser. The early reports looked at 810 nanometer laser or red infrared laser. And they found that they had most of the absorption at the RPE and very minimal absorption of luteal pigment, medial opacity. In fact, can get through vitreous hemorrhage quite well. The power that you need to use, especially if you're going to use it for continuous wave, though, was quite high. And so sometimes can be a little uncomfortable for patients. And so again, we chose 532 in our previous practice. 577, though, really is gaining a lot of popularity. The maximal absorption here is at melanin oxyhemoglobin, and with very minimal absorption of xanthophyll. The power is kind of in between 532 and 810. One great thing about D577 is really you notice the spots really don't expand after you place them, unlike 532, which can over time. Now with 532 laser, again, it's quite safe even for foveal absorption, but I do find that 532 does have some absorption of melanin. And that's why I do find that I think 532 perhaps has some changes with pigmented eyes, which is why I do a titration spot for my 532 patients. So that brings me to my preferred settings. In my current practice, we use an IQ 532 that has Texcel or pattern laser capability. I use a 200 micron spot size at 200 millisecond duration. I don't change any other parameter other than the power. And I feel that that's because you don't want to change the fluency calculations at all. Because again, when I'm titrating, I do want to try and be as accurate as possible. So I take that spot and I titrate it at a continuous wave burn outside the area of edema. Then I multiply what is a standard focal burn, so my normal sort of gray burn, by 3. And I only go to a maximum of 400 milliwatts. I always do 5% duty cycle. I never go more than that. That is extremely important. In fact, when I used to have a scribe, I would have them tell me what my duty cycle was before I would start the treatment. Currently, I do utilize the ease of a Texcel pattern grid to speed up my treatments. I do a 7x7 grid with 0 spacing. And the reason is you do want a highly confluent treatment pattern. So I'd like to go further and talk a little bit about some of my cases that I've done. So the first is, it was a 73-year-old Asian gentleman who presented to me in 2019 with a diagnosis of polyportal chordal vasculopathy. His vision was as listed, and he had been treated Q4 weeks with aflibercept by a retiring retina specialist in another practice. This was his presenting OCT with kind of low-level exudation. This is his first scan. After treatment with me, he presented actually in June, and I decided to continue his same Q4 week aflibercept dosing. And you can see it did improve, but there's still some persistent PED, and the patient remained with metamorphopsia. So we had the advent of brolucizumab around this time, and I was excited about using that for polyportal. And actually, the patient had a wonderful result after 4 brolucizumabs. You can see nearly flattened PED at this point, and the patient was extremely excited, felt that he was able to read a newspaper for the first time. But then we started seeing the issues with intraocular inflammation. And so I switched him away from brolucizumab and went back to aflibercept. And you can see within a month, he had a dramatic recurrence of his PED as well as associated subretinal fluid. So at this point, I decided to try MicroPulse because he was very disappointed with Q4-week Eylea or aflibercept. And so I decided to see what I could do with another modality. These were his photos. I do think it's very important when you are treating any patient with MicroPulse to see what the vascularity looks like. If you look at his PED from his OCT or his infrared image, you might not actually see the areas of leakage. And so you do want to make sure that you're covering the entire area instead of what just looks like the PED on your scan. So you can see after one treatment, he actually did have a significant improvement. And what I would like to stress here is this is not a one and done. This is the goal was to sort of reduce his treatment burden. So he did have a slight recurrence early in 2021. So I did repeat his aflibercept, but he had an incredible result. And so you can see this is here most recently in August of this year. I just saw him a few weeks ago. And so since October 2020 till now, he's had one retreatment of Eylea. So again, a very, very excited patient with a single MicroPulse therapy. This was another woman of mine who's 56 and was a professional at a corporation that was actually an hour and a half away from my office. She developed a BRVO with macular edema back in 2014 with very significant vision loss and a very significant central foveal thickness. With regular treatment, she actually did quite well with a vision of 20/30, and you can see a very dry retina. But she started to develop tachyphylaxis of aflibercept and started losing, started actually getting edema even at a 4-week interval, and her vision actually started dropping to 20/60. She also told me I have a lot of difficulty making it to these appointments. I have to take off work every time, and it's a 3-hour trip because she was driving an hour and a half each way. Is there another option for me? So at this point, we talked about MicroPulse therapy, again with an IQ 532 laser. This is 1 month after her laser. This was the vertical raster, and she already had a significant improvement in her fluid. This is now a year after. Her vision continues to improve, and her fluid actually arguably looks better now. I'm now just following her every 4 months. This is now 6 years from her initial treatment, and she obviously could not be happier. So she went from someone who's getting treated every 4 weeks on Eylea to really not needing a further injection. Now, again, all results are not equal. Patients are not created the same. So here are some of the considerations that I've thought of through the years. So when we think about treatment burden, every single patient has a treatment burden. That's the way that I approach this. It is not easy to come and have a needle put in your eye. It works great, but it is a burden. I definitely find that this is great for patients who are younger, who are working, while have a lot of difficulty making it in. I do think phakic eyes are easier. For some reason, I think that the actual treatment seems more and more consistent when I do it through that, and I'm not fighting through any of the lens capsular issues. And social considerations are very important. Again, we are battling through the COVID era, and we're having a second very significant wave right now. So being able to keep these patients, especially immunocompromised patients, out of our office is an extremely important consideration. One thing that I've also tended to notice is I find that patients who are very responsive to pharmacology, that actually do well, that just have a lot of variability, meaning that big sort of accordion effect, seem to be the ones that do better. I find that the ones where they're barely moving and I just try MicroPulse as some other option don't really seem to be that beneficial. But it's not necessarily that the MicroPulse isn't working. It's probably nothing's going to work for those patients. So I definitely want us to sort of expand the way that we think about MicroPulse therapy for some patients who may need it. So thank you very much for your time. What we will do is probably try and address some of the Q&A questions at the end. If there may be quick things that we can address, maybe one of the other panelists can also chime in as well. But for some of the bigger questions, I think maybe we will do a roundtable discussion at the end of the presentations. All right, so thank you very much. I believe Dr. Goldberg is going to be following me, so thank you very much.
Dr. Luo, great talk. All right, so I'm going to kind of continue the themes that Dr. Luo started, and it's really interesting. Even though Dr. Luo, Caesar, and I are partners in the same practice, we actually do things a little bit differently. And I guess that's probably true with lots of things, not just MicroPulse, but there's certainly more than one way to skin a cat. So I'm going to talk about kind of my perspective on some of its utility in macular diseases, particularly around diabetic macular edema and central serous chorioretinopathy, and some of the tips and tricks that I've experienced and developed over the years. And you'll see that some of them are a little bit different than Dr. Luo, and maybe at the end, we'll have a chance to kind of discuss those differences. So with diabetic retinopathy and DME, we know that the risk factors for developing diabetic retinopathy and DME include uncontrolled hyperglycemia. For every 1% increase in the A1C, there's a 50% increase in the risk of diabetic macular edema. How long a patient has had diabetes and whether they have concurrent hypertension as well are all risk factors for patients to develop DR and DME. In the US, the population of patients with diabetic retinopathy is expected to double to about 15 million patients by 2050. Interestingly, and I know we've got a lot of attendees on this panel from all over the world, this doubling rate is holding true all over the world, in basically every country you look at. So the burden is going to be really a global burden. The historic treatment of DME, of course, if you go back a long time ago, was focal laser, and that actually was, good for reducing the risk of vision loss by 50%, but few patients actually gained vision with focal or macular grid laser. And there were certainly complications of it. Obviously, where you put in a thermal burn, the patients get a scotoma. The laser scar can expand, sometimes double or triple in size over 2 years. You can get secondary choroidal neovascularization with associated subretinal hemorrhage, and you can get atrophy in the area where the scar is. So focal laser was largely replaced by anti-VEGF therapy, which offered the promise of significant vision gains, as Dr. Luo and I think probably everybody on this webinar knows. But to achieve these incredible results, this is from the Rise and Ride study, the patients required monthly injections. And what do we see in the real world? Do patients actually achieve those incredible results? No, they don't, because it turns out that in the real world, we significantly undertreat our patients. There is this incredible burden. And interestingly, in these two studies, approximately 50% of our patients with PDR, the most advanced form of diabetic retinopathy, are actually lost to follow-up kind of in the real world. And it's interesting, I don't think as physicians we're great at following or thinking about our lost to follow-up patients because we only see the patients that are in front of us. We don't see the patients who aren't in front of us, who haven't come back in. So can MicroPulse play a role here? Can we help improve the vision in patients who've lost vision? Can we reduce that injection burden? And can we stabilize the patients with good vision? And I think the answer is yes. Actually, Larry Morse and his colleagues at UC Davis did a really nice retrospective study looking at 19 eyes with DME that were treated with MicroPulse versus ranibizumab or Lucentis. Both groups gained similar visual acuity at all time points, but the MicroPulse group required significantly fewer injections. There were, at the 1 year time point, it was 1.7 injections versus 5.6. And at the study end, it was 2.6 versus 9.3. That was about 18 months on average. So what are some of the kind of key key takeaways when I read this paper, and I've seen Dr. Morse present this work before. Number one, MicroPulse was used relatively early in the treatment course. So this wasn't kind of these chronic recalcitrant end-stage diabetic macular edema eyes. MicroPulse was used early in the treatment course, typically when patients had received somewhere between 0 and 3 injections. And I think it works better with milder disease. And Dr. Morse found that as well, that the MicroPulse was more effective when the DME was less than 400 microns. So for that really thick and swollen retina, I think a little bit of induction therapy with anti-VEGF can help. But if you're so end stage where even the anti-VEGF injections or steroids aren't working, and then you say, well, let's try MicroPulse on that patient, I think you'll kind of have an unsatisfying response. Whereas if you use it early in the course of treatment, that's when you can really see a difference and reduce your need for kind of chronic injection therapy. So here was one of the cases from Dr. Morse. I think this is a, pretty significant level of diabetic macular edema, 20/50 vision, given MicroPulse treatment at baseline. And at 12 months, oh, that's funny. At 12 months later, the patient had received 2 Lucentis injections, which I think over a 1-year period, I think we'd all argue and recognize that, hey, that is a great outcome. Significant improvement in the intraretinal fluid and the central macular thickness, and most importantly, the visual acuity improved from 20/50 to 20/25. So great answer, great result there. And I think it really highlights some of the points, and you'll see the same things come up here when I talk about central serous retinopathy. And I'm going to start this one with a case. This is a patient of mine with who'd actually had reduced fluence PDT in 2011 for chronic central serous. The fluid resorbed. His vision was 20/20, but he never felt like his vision really recovered, and he had a scotoma, relative scotoma right below fixation, and reported kind of trouble with his color vision, dyschromatopsia. In 2015, he came to see me. The fluid had recurred and his vision dropped to 24/8. And here you can see the fluid, subfoveal fluid. And this is his scan. And you can see actually like a almost perfect circle where the PDT had been applied back in 2011. And this is really where the patient was complaining, even when the vision was 20/20, about that relative scotoma. Because when we look carefully at the OCT, now this is when he's recurred in 2015 when there's subretinal fluid there, but he really has no photoreceptors left against the external limiting membrane there. So a very poor photoreceptor layer, which is why he had this kind of permanent scotoma from the PDT. So he was adamant he did not want more PDT, and I said, let's try MicroPulse. I did a 200 micron spot size, 400 milliwatts with a 5% duty cycle, and I'll go through my settings at the end. And I applied it confluently to the serous RD. And 2 months later, the fluid had resolved. He was 20/20, very happy. And you can see up above, this is where he'd had PDT previously. There's still like a disruption in his photoreceptor layer. So he's kind of left with a bit of a scotoma from his prior PDT. There was actually a randomized controlled trial that was published in 2015 comparing MicroPulse to half fluence or reduced fluence PDT for chronic central serous. And the results are pretty similar. 24 patients in the half dose versus 20 in the MicroPulse. They gained 8.5 letters versus 6.7 letters. Observation only 1.5 letters. So no statistical difference between PDT and MicroPulse. They actually looked at fluorescein angiography leakage area and showed a pretty similar reduction in the leakage area. And the takeaway from the authors was that MicroPulse was a good option for patients with acute central serous or a shorter time of onset of the disease before the loss of the IS, OS, and visual functions become irreversible, whereas PDT seems to be a good treatment possibility in the chronic progressive forms. And so again, kind of my insider tip here is MicroPulse is best used early in the disease course, just like we saw with Dr. Morse's patient in diabetic macular edema. So PDT, although some people call it kind of the gold standard for chronic central serous, and oftentimes people will wait on fluid and just see if it goes away on its own. But that fluid can be very disabling. This is a quote from a patient of mine who really struggled afterwards. And I think MicroPulse offers our patients an opportunity for us to intervene early in the disease course before some of these changes become permanent. So some of my tips and tricks, well, just like Dr. Luo said, there is a learning curve. There's definitely a tendency to undertreat at first. You want to go kind of low intensity and high density, so very close spot size. One spot kind of really just immediately adjacent to the next spot. Have patience with it. It's a slow and steady response. It's not a kind of instantaneous. So you don't have that kind of immediate response like you get with an injection, where if you see an injection patient 1 week later, usually the fluid's a lot better. I think MicroPulse works best in early in the course of these fluid maculopathies, or when the fluid's more mild, and it can really be adjunctive in some indications, like Dr. Luo pointed out. One thing I think that's really important is that the focus of your laser beam still matters. So focus still matters for sure. And it's interesting to hear Dr. Luo, even though we're partners in the same practice, he does 7x7 with the tech cell pattern. I actually prefer to do one spot at a time. And I feel like that gives me a little bit more control in terms of my placement. Sometimes with the tech cell, it can kind of take a moment for all 49 spots to get placed. So I tend to like just doing the individual spots one at a time. And I always confirm that I'm not in continuous wave mode. Dr. Luo had mentioned that as well. And I typically will, it's definitely repeatable. I typically repeat it if it's necessary. About the 3-month point would be the soonest I would do it again. But usually that's not needed. And, I have repeated it as soon as 3 months. So I use a 200 micron spot size with 400 milliwatts, 200 millisecond duration with a 5% duty cycle. I use an ocular Mainster focal grid lens. This has no magnification provided by the lens, so it's truly a 200 micron spot size. And as I was saying, I do single spot. Dr. Luo talked a little bit about the differences between 532 and 577. And maybe there's some theoretical advantages with 577. I use 532. It's what we have in the practice. It's also what I trained on in fellowship. And because we're using it as MicroPulse, we're not getting scarring of the RPE. So there's no, spot size creep where the spot gets larger because we're never putting a spot. This is subvisible MicroPulse laser. And so I'm sure, I can imagine we might have a little discussion on this at the end, but those are some of my tips and tricks, and I'll pass it over to Shawn.
Thanks so much, Roger. That was absolutely fantastic. That was a great talk, and it was a good way to be able to see some of the burden that we're about to start facing, especially in the world of diabetes. So I appreciate that, Roger. And yes, I think that we're going to have a great discussion at the end about some of our treatment parameters and what we have found most effective. So thanks again. That was a great presentation. We've already had some great questions that have popped up that, again, we will definitely address at the end. So Shawn, take it away.
All right. It's good to be with you all from Houston. Thanks for tuning in. And thank you, Caesar and Roger, for your great talks. Hope everybody can see my full screen okay. And I'm going to share my 1 year of experience of incorporating MicroPulse into my retina practice in Houston. So the situation was I'd been in practice at a multi-specialty group for a few years after finishing fellowship, and I decided to start my own solo retina practice with the opening date of June 1st, 2020. I had no direct prior MicroPulse experience, but I had friends and colleagues at other retina practices in town who had the MicroPulse and had been using it with good results. And I was eager to learn more about it and try it. So when I was setting up shop, there were a few key pieces of equipment that I needed. You know, obviously I needed my OCT. The fundus camera, I thought of it as more of a luxury, and certain OCT units have a combined fundus camera option. I needed a laser, I needed a B scan, and I needed my exam chairs and slit lamps. So after 3 years in the previous practice at the multi-specialty ophthalmology group, there was no MicroPulse at that practice. It was an injection heavy practice. There was a lot of AMD, a lot of diabetic macular edema, retinal vein occlusion in Houston, where high blood pressure and diabetes are pretty rampant here. And we had a continuous wave laser without MicroPulse, just a traditional thermal laser, 532 argon, and we had it available all the time for retinal tears, focal laser for eccentric microaneurysms, diabetic macular edema, and then of course PRP for proliferative retinopathy. But when I was deciding what kind of laser I wanted to incorporate into my practice, it was really CSR that tipped the scales for me. I wanted something that I could use to treat these patients for CSR, because for the previous 3 years, when a CSR patient was sitting in front of me in the exam chair, there were a few less than ideal options that I could give to them. Number one, just monitor, do nothing, inform them that it's most likely has the potential to resolve on its own after 3 to 6 months. But it's not really satisfying to be somebody's physician and say, I'm not really going to do anything for you. I'm going to sit on it, even if they're bothered by a central scotoma and their work is impaired. Another option is a Plerinone or Inspira. It's a pill that you can give, 25 milligrams. Take it daily with a long list of side effects: dizziness, diarrhea, cough, flu-like symptoms, fatigue. Good luck telling a 40-year-old type A male that they could potentially develop gynecomastia from Inspira. And so that was a less than ideal option as well. And then the third option was just refer out. These are the two options, and we don't have a MicroPulse laser at our practice, so I'll send you to my buddy at the neighboring retina practice and he can take care of you there. So I wanted something in my practice that I could offer for the CSR patients. So one option would be PDT, buy a PDT laser, but this is how I felt when I was thinking about PDT is, where do you find a PDT laser? Where do you find somebody who's experienced in injecting verteporfin? And then you have the issue of patients have to avoid the sun for 5 days, which is pretty difficult here in Texas. And then the other thing is, where are you going to find somebody who's actually a PDT candidate, somebody who's, recalcitrant to anti-VEGF injections, or somebody who fails MicroPulse laser. So finding the machine, number one, and number two, finding the PDT candidates would be difficult. So I decided I needed a MicroPulse laser in my practice. And there were two setup options. Number one, this is the old practice where you had the laser. It wasn't MicroPulse, but it was a laser unit that attached to a free slit lamp adapter to attach to any slit lamp in the practice. So the thing is, the laser can travel with you wherever you go. You could set it up that day. You could take it to a satellite office. It's mobile. And the other option is to buy a fixed unit here on the right with its own table, and it's mounted on the table and mounted to a slit lamp that the Iridex provides. And so I opted for this option on the right because I had a specific room that I had in mind for the laser. And it worked out great for me because I was able to offer something immediately to my CSR patients. This was a case here that I would never forget. This patient came into me on January 12th of 2021 with huge subretinal fluid. This was, the reason why I won't forget this, not just because it's a unique case, but because it was the day after I got the second dose of my Pfizer vaccine, and I was having the headaches and the chills and all those symptoms. And he was sitting there and he wanted something for a CSR, a typical type A guy, 2200 vision, difficulty working. And, even in my, sweating, feverish condition, I was able to deliver a successful treatment for him that same day. I didn't have to wait a few months. I didn't have to refer him somewhere else. I could just offer him a treatment right there, a safe and effective treatment. So treatment date was July 12th, 2021. And here he is just 5 weeks later on February 19th, 2021, and the fluid is all resolved and the vision recovered to 2020. And so that's been my experience with MicroPulse for, fortunately, every CSR patient that I've had in my practice over the past year. And they get to stay with me in the practice. I haven't sent them elsewhere. And another thing that really drew me to the MicroPulse was the versatility of the laser unit in general. It's a single unit that comes with the slit lamp that I could use both for diagnostic and therapeutic purposes in one room. So this is my laser room here in the office. And I'm not sticking the laser somewhere in some other room that's going to remain unoccupied for the entire day if I'm not doing a laser. Okay, this is an excellent slit lamp comparable to a Hog straight. And so I could use it as a diagnostic slit lamp. It has the blue light, it has all the filters. And then I could change it over to the therapeutic option when I want to actually deliver laser treatments. Traditional continuous wave thermal laser, slit lamp delivery for the microaneurysms and the eccentric DME, posterior retinal tears, PRP, and then I could switch over to the indirect headset here for the peripheral retinal tears with scleral depression, and PRP for PDR and wheelchair-bound patients. And then finally, it has the MicroPulse option to be able to switch over to MicroPulse treatments for CSR. And then what I wanted to see next was, could I incorporate this into my DME patients, my RVO patients, and my neovascular AMD patients to try to reduce the injection burden, as Caesar and Roger have been discussing. So there was data out there suggesting that MicroPulse is useful for reducing injection burden for both DME and neovascular AMD, and I was eager to try it. So here's a case of a 48-year-old phakic male with type 2 diabetes, and he had a history from another provider getting monthly Eylea injections. I believe he'd had about 6 injections, and the last one was about 3 months before he was referred to me. So you can see here on the fundus photos, there are microaneurysms and surrounding exudates in both eyes, but the visual acuity was 20/20 in the right eye. OCT looks pretty pristine with a tiny cyst there. And on the left eye, the vision was 20/30 with a larger cysts parafoveal and really kind of extending into the foveal area. So he was symptomatic in that left eye. And so I gave a Eylea injection a couple weeks later after getting the authorization on the 29th of July. So this was just 2 months into my practice, one of my first patients. And so here he is on September 4th, a few weeks later after the Eylea. The right eye is still stable. And the left eye, there is improvement in the intraretinal cysts, and the visual acuity improved to 20/20. So here at this stage, he's 20/20 now. He can read the smallest line on the eye chart, but there is persistent fluid on the OCT. So what do we do? In a 20/20 eye, should we repeat the Eylea injection? Should we try another injection? Or does the risk of injection outweigh the benefit? So in my opinion, and Roger and Caesar, I'll be curious your opinion on this as well during the panel stage, but for a 20/20 eye, I'm pretty hard pressed to put a needle in the eye. I think the risk outweighs the benefit. There's a less than 1 in 5,000 chance of endophthalmitis, but it is an invasive procedure and you don't know what's going to happen. Are they going to go home and do yard work? Are they going to get sweat in the eye and maybe develop an infection? But at the same time, I don't like the fact that there's still intraretinal fluid on this OCT. So this leaves the potential for some photoreceptor damage. And if we do nothing, yeah, sure, he's 20/20 now, but is he going to be 20/25 in a couple months, maybe 20/30 after that if we leave it alone? So I also don't want to let somebody get worse. So given the 20/20 vision, we discussed that and we decided that we're going to defer an injection, but we recommended doing the subthreshold MicroPulse laser to stimulate the heat shock proteins and try to stimulate additional resolution of this intraretinal fluid. So on September 21st, 2020, a couple weeks after that, we did the MicroPulse laser on the left eye. So I put one spot right there to target that microaneurysm with the surrounding exudates. And I got the gray burn that I wanted. So then I multiplied the power. It was a 50 milliwatt power to get that gray burn. And then I multiplied the power by 3. I had a conversation with Caesar as I was actually initiating MicroPulse into my practice. And so we went over the settings together. Caesar, you probably remember this. And so I multiplied by 3 to 150. And then I delivered confluent 266 spots all the way up and down the macula, just like this, including this microaneurysm exudate area. And so he tolerated the procedure well. And here he is a month later, and he had bionic vision. He was 20/15 actually in both eyes, so he was feeling really motivated that day. And the intraretinal cysts had improved. They shrunk even further compared to the month prior. So we monitored at that visit. And then a couple months later in December, the cysts are still shrinking. He's 20/20. We monitored without treatment. 3 months later, he's 20/25 now in the right eye. The other eye is developing enlargement of that small area that he initially presented with. And then in the left eye, he's still 20/20, but we're getting a little bit of enlargement again. So we opted for MicroPulse in the right eye, followed by the left eye. Here we are 3 months later. This is now June 14th of 2021. So almost a year after he initially presented to me. And he's still 20/20 in both eyes with improvement in the intraretinal fluid on both OCTs. And so we repeat the MicroPulse, first in the right eye, then in the left eye a couple weeks later. And here he is on, this was the MicroPulse day for the left eye. We just have a tiny cyst left over there. So in this case, and in many other cases in my practice for both DME and neovascular AMD, I found MicroPulse to be safe and effective for patients with 20/20 eyes. So we don't have to introduce the remote risk of a serious complication from an injection. So in the pandemic, MicroPulse is a really nice option because it has the potential to reduce the injection burden and space out the visits. It's hard for the patients to take time off of work and to come in. And especially for our elderly patients who are at risk from developing life-threatening complications from a COVID infection, it benefits them not to have to come in as often. And we have an opportunity to extend to 3 months or beyond. Now, one of the solo practice considerations that I've experienced is drug inventory. There are reasons for insurance denials, such as prior authorization, either the initial authorization or the renewal authorization for the high-cost drugs like Eylea and Ozurdex. But with MicroPulse Laser, I found that the vast majority of plans don't need prior authorization. So if the patient's sitting in your exam chair and they need or want something that day, that's something that you could potentially offer right away without needing authorization. I've also found that the insurance companies require that we submit medical records or submit an NDC number for the drug in order to get it paid for. You never get anything like that with the MicroPulse Laser. Sometimes they require the medical records, but definitely not an NDC number. Other issues like a PCP referral expiring, or there was one case where a patient needed to update his COB certification of benefits questionnaire in order to get a high cost injection approved. If, God forbid, if there's a denial, then that's inventory that's lost and you can't get back for a high cost drug. But worst case scenario, if a laser is denied, you didn't actually put up any funds initially that could never be used again. The laser is a one-time cost and it stays with you for the duration of the practice. There are some supply chain hurdles that can occur with injections. We had the famous winter storm in February, and I happened to have ordered several high-cost drugs the day before the storm arrived. And so, obviously, the UPS delivery didn't make it that day. And so once I was finally able to see patients again, there weren't any drugs available for them. And so the laser just sits with you in the office, and if they need a treatment, that's something that could be done. So for the case selection, there's data out there that suggests, and I completely agree, that I found that central foveal thickness less than 400 microns, they tend to be the ones that do the best with MicroPulse laser, whether it be DME or neovascular AMD. And so for my settings, similar to Caesar, I use a 200 micron spot size, 200 millisecond interval, 200 millisecond duration. And I can often combine the treatment with a targeted continuous wave thermal focal laser for the microaneurysm. So I'm combination sealing the microaneurysms while testing for the titration power for the MicroPulse. And then I multiply by 3 and switch to the 5% duty cycle. So for example, if I get a slight gray burn with the 50 milliwatts, then I multiply by 3 and I use the MicroPulse at 150. Or if it's 130 milliwatts in a Caucasian patient to get a slight gray extramacular burn, and I'll multiply by 3, but if it exceeds 400, then I'll cap it at 400, just like Caesar does. The lens that I use is the Area Centralis from Volk, and I haven't had any problems with fogging of the lens with the patients wearing masks during the pandemic. And for now, I also use a single spot size like Roger. And so one study looked at the comparison between fixed and variable power for the MicroPulse, whether you just do a flat 250 milliwatt for everybody versus do the titration, and they actually multiplied by 4 for their titration, and they found no major differences between the 2 treatment groups. But for now, I'm still a titrator. So that's the end of my talk, and I thank you all for joining us and look forward to opening up to the panel for questions.
Sorry, Dr. Rizzi, that was absolutely brilliant. It's so funny, even with the experience of MicroPulse that I have, every time I see results like you and Dr. Goldberg have presented, I'm fascinated with how well this can work for the right patient. So wonderful job. I almost feel like you've graduated from Caesar MicroPulse Academy. I feel like I'm seeing my my younger self here doing MicroPulse. This is absolutely wonderful. So great results, and I'm definitely looking forward to hearing some more tips from you guys. So something that's come up several times now, I think, Roger, you had mentioned it briefly as well. What are your retreatment criteria? So Shawn, we saw there in your presentation, it looks like you were retreating eyes kind of every 3 months if necessary. What are some of the things you look at, and how do you approach retreatment?
Yeah, so for me, I'll look at the OCT and I'll look at the visual acuity. Those are my 2 main markers. And so if I see a slight dip in either, but if in my eyes they still remain a candidate for MicroPulse, you know, if there's a reasonable central macular thickness where I think they would respond well if they're under 400, which most of my MicroPulse patients are, then there's really no risk to delivering additional MicroPulse if you get the settings right. So, you know, it's painless, it's harmless, and it's something they could use without getting an injection.
Great. Roger, along the same vein, if there's a patient that has shown a response to their initial MicroPulse, but then recurs, would you find that that's someone that you would then want to retreat with MicroPulse, or would then you switch them over to an intravitreal therapy? I guess the question really is, which patient would you retreat? Like, let's say you try MicroPulse on a patient and they seem to have moderate improvement, but not a lot. Would you then try and give a second dose of MicroPulse?
Definitely. And, you know, I tend not to think of all these therapies as kind of mutually exclusive, particularly in our diabetic patients. A lot of these patients, they kind of need the kitchen sink, you know? So sometimes what I'll do is, you know, I'm not a titrator. The way I titrate my treatment isn't by titrating the power. It's by titrating the number of spots, the location of the spots, and the retreatment criteria, and how quickly I'll retreat. And it reminds me of the way, like, we don't titrate the Eylea dose we inject into the eye. We always inject 2 milligrams, but we titrate the interval with which we treat them. So to me, the key question when I think about MicroPulse and retreatment is, did I see some response? If yes, I look at that and say, hey, that's a good thing. And if it's if it's an excellent response, but then whatever, a few months or 6 months later it recurs, no qualms, just repeating MicroPulse. If it's an okay response, then I go back and I look at my settings and I'll try to document like where exactly, I always document the spot size, but where I treated. You know, did I go straight through did I go through the foveal center, or did I go kind of more FA guided, just to kind of where I thought it was leaking the most. And so I'll look back at that and say, well, geez, maybe I should have, been more aggressive. And particularly, I think early on, I was, like I think everybody, you're a little timid treating through the fovea at first. And knock on wood, I mean, I've now done it, all the time, and I have never seen a MicroPulse burn. And so you just get increased confidence the more and more you do it, to treat right through the fovea. And then the other thing I'll do is sometimes I'll do combo therapy. So, there are some long-acting, ultra long-acting steroids that I think work better once the edema is under control. And so sometimes I'll give an anti-VEGF injection, then I'll say, come back in 2 weeks. And because the retina is a little bit thinner, it looks better. And then I'll apply the MicroPulse. And so sometimes when I've had a suboptimal response, I'll look to say, well, what could I have done differently? To say, let me try, to try and do something a little bit different this time as I retreat.
That's great. Yeah, I'm right along the same lines as Dr. Kavoussi and Dr. Goldberg. I think it's not just kind of retreat everyone, but I think if you think about it a little bit and see what actually makes sense, those are the right patients to retreat, and you retreat them as needed, just like Dr. Kavoussi presented in his case. A little bit kind of just hopping on that as well, kind of treating over the fovea center. I think that is something that a lot of folks who are first starting get very nervous about, just like Dr. Goldberg said. In fact, one of the questions here is any experience with macular ischemia after MicroPulse therapy. In that study that I first discussed, we actually did fluorescein angiography on all 100 eyes after their MicroPulse therapy, and we found no evidence of angiographic burns or ischemia after their MicroPulse therapy. There is a way to do it though. Again, if you are doing 50% duty cycle, that's absolutely a possibility. So you just have to make sure that you are doing it safely, and it is absolutely fine. What do you guys think?
It's interesting because it's not clear what the role of all those, I actually am not sure how much Iridex lets you titrate the duty cycle. I think you can do 10% and 5%. But
yeah, I think it caps at 15.
15. Right. Okay, so that is like a built-in safety feature, Caesar, to prevent that. And I should give just one other comment. I often will do a single burn, like up near the arcade of continuous wave, mostly just to make sure like the laser's working, you know what I'm saying, before I go straight to MicroPulse. So I do like to see kind of one, barely visible burn, somewhere kind of irrelevant to the patient's vision or to the patient's pathology, just to know like, okay, everything's working and whatever, the fiber optics are all aligned, and then I'll go and apply the MicroPulse at my standard settings. I also have never seen macular ischemia associated with the application of MicroPulse. I should say it also doesn't reverse macular ischemia that's there, so it's not like it's a treatment for macular ischemia, but I've never seen it kind of either cause it or treat it.
Yeah, I agree with Roger. I think you're testing the laser and the focus by putting that extramacular spot, and then Caesar and I, by doing the titration, we're testing the laser as well, because if we're not getting any kind of gray burn, we need to set the power so that we know that there's some uptake. And as Roger, you said in your talk, the red beam has to be in perfect focus in order for it to work. If a patient has too much of a cataract and there's too much scatter of the laser beam, then you're not going to get any kind of response. And then couple months later, you'll see that there was no response to the MicroPulse, and you'll think that it just didn't work for the patient, but it just might be that it wasn't the right time.
One of the things, actually, Shawn, I was reminded of is you were talking about, because you really talked not just about MicroPulse, but just about the utility of the Iridex platform having both continuous wave and treating peripheral pathology. And I remember an issue I had with one of my partners, Caesar. This may have been before you joined, but he's like, I was doing PRP and I turned this, I literally had to turn the power up to, I think it goes up to 2000, and he couldn't get a burn. And it was because he didn't realize that the duty cycle is at 5%. So you have to make sure when you're doing PRP and, or lasering a retinal tear, that the duty cycle is back to normal.
That you turn MicroPulse off.
Exactly.
Exactly. Well, that's an interesting question too. So Dr. Kavoussi, you had mentioned about using focal laser, continuous wave burns for extramacular microaneurysm. So is that something that you still do in conjunction with MicroPulse, or do you just do focal for those areas?
Yeah, it depends on the eye. If there's somebody that has a pretty large eccentric hump with a clear source of leakage and the fovea is still pretty decent, but then there's scattered intraretinal fluid throughout, that's somebody where I definitely want to seal that area of leakage temporally, extramacular, and then MicroPulse throughout the rest just to strengthen the heat shock protein for the remainder of the macula. But if somebody's kind of flat all the way across, a few cysts here or there, they just might be a straight MicroPulse person for me.
Got it. I do the same. If I see a juicy microaneurysm, I'm going to hit it with continuous wave burn, and then I'll blanket the rest with MicroPulse, and I think it works really well. On that note, also sort of the combined MicroPulse continuous wave burn, there's an interesting question in here about a patient that has severe PDR and macular edema. I personally have not done this, but either of you guys have done PRP in conjunction with MicroPulse at the time of the PRP therapy?
No, I've never done PRP at the same time as MicroPulse, but theoretically you could. Just as long as you're aware of what your settings are at the time and be sure you switch it over to the 5% duty cycle before you treat the macula.
Sure. Yeah.
Yeah, I also have not done that a little bit. I tend to be kind of a one step at a time person. So if there's macular edema and there's PDR, particularly if it's not like a tractional PDR, I usually will give an anti-VEGF injection to acutely control the diabetic macular edema and then put in PRP to, treat the PDR. And, but as we talked about, MicroPulse is a little bit of a slower process. And sometimes if you do PRP, you can make that diabetic macular edema, a lot worse very quickly. So I think having a short acting agent like an anti-VEGF works well for those cases, and use the MicroPulse really for chronic control of the disease.
Yeah, I agree with Roger there. You want to shut down the impetus for macular leakage much more quickly with an injection like an anti-VEGF before adding the PRP and risk worsening the macular leakage.
Yep, I'm exactly the same as the other panelists, so great. Let's pivot a little bit then to CSR. That's something that both you guys have discussed here, and it is interesting. So one of the questions that came up earlier was, what is the level of fluid that you would comfortably treat with MicroPulse? And my response to the attendee was, I don't like to treat a patient that has very, very thick, dense edema. If they're greater than 400 microns of fluid, I don't think that the laser works quite as well over that area. But CSR is a little bit different. I mean, CSR, some of these patients have dramatic fluid. So do you guys have a level of fluid for CSR, or do you see your patients first day and then start treating? Dr. Kavoussi, what do you think?
Yeah, I mean, I will let the patients know that they may be less likely to respond as quickly with a large amount of fluid, but I don't see any reason not to treat everybody with MicroPulse, whether it's large fluid or whether it's small fluid, because if you have the right settings, then there's really no risk, there's no downside. You just have the potential to speed up the resolution more quickly.
So you find that the MicroPulse might act a little bit. So in your experience, would you also agree that MicroPulse, certainly for diabetic macular edema or macular edema secondary to RVO, that if it's very significant, it doesn't work quite as well?
I've had the same experience. Yeah. So
Okay.
for DME, RVO, I haven't had as much success with thick fluid greater than 400 microns, but for CSR, I have. And that case that I showed in my talk was a pleasant surprise of, how quickly he responded, given where he started from.
Yeah, I'll give a slightly different perspective, which is acute CSR, which is characterized primarily by subretinal fluid. 100% agree. Doesn't matter. Those patients still have a healthy RPE, and you activate the RPE. Whether it's we all it's a little bit of hand waving, but we know from like animal data that it seems to activate heat shock proteins and kind of rev up the RPE cells, maybe to work better in their pump function and pump out the fluid that's under the retina. And so I think for subretinal fluid in an acute CSR case, there's no limit, 800 microns, no problem, as Dr. Kavoussi's case showed. But I think for chronic CSR, where it's oftentimes characterized by, first of all, a lot of RPE, damage, and typically not so much subretinal fluid, but much more intraretinal fluid. And sometimes people call that like sick RPE syndrome. And that's when I find, like, if the RPE has dysfunctioned so much that you're greater than 400 microns of intraretinal fluid, I think kind of activating those like dying RPE cells to try and pump a little bit more and deturgest that retina, that's where I find PDT, where you're actually trying to kind of turn down the spigot rather than increase the drain, maybe works better. And so I find for really thick, boggy, sick RPE and like that end stage chronic CSR, PDT works better. But for, and that's where I think MicroPulse kind of treating early in the disease, because ultimately our goal, frankly, should be to prevent any patient from getting to that end stage disease, period, end of sentence. Like, that should be our goal. But that's where I feel like MicroPulse really plays a strong role, is before we get to that end stage disease. So anyway, to me, I differentiate by 400 microns intraretinal fluid. If it's subretinal fluid in acute CSR, I think MicroPulse still does well.
I think that's a fantastic point, Roger. I think that historically we have all kind of watched and waited for CSR, and it doesn't really make sense. I mean, us as retina specialists don't tend to just let something go. And especially since these are already sort of patients that tend to be more anxious at the onset, to be able to offer something to them earlier seems to make a whole lot of sense. So that's a great point for sure. So few kind of interesting questions here. So one question was also about using MicroPulse therapy as the PRP for PDR. That's something that I have actually considered and discussed with Iridex in the past. But what's interesting, almost like treating over the fovea, in the beginning, I was very nervous to do that and felt more comfortable over time. This is the same thing. Part of me feels a little bit nervous that I'm under-treating their proliferative disease with MicroPulse PRP. So I personally do not have any experience with that, but I know that people are trying it. Dr. Kavoussi or Dr. Goldberg, any experience from your end?
I have not used it, but I saw a phenomenal talk with Mark Blumenkrantz and Daniel Palenker, who I know that the Pascal laser is now kind of, and some of that, their pattern treatment's going to kind of fold into the Iridex MicroPulse family. And they were really the pioneers there. And they've showed some pretty compelling animal data on kind of the oxidative demands when you do this kind of MicroPulse or subvisible PRP. And they'll actually often kind of mark with like a visible burn in the kind of squared out, so you can kind of see, oh, this is where I placed, this MicroPulse PRP, but I have not yet done it personally. Usually by the time I'm doing PRP, it's like I'm worried about that patient falling off a cliff or not coming back to my clinic for a year or longer. And so I don't want to kind of take any chances with that patient. So a little bit, I just end up doing the kind of tried and true.
Yeah. What about you, Dr. Kavoussi?
Same here, no personal experience with that, but there are patients, the majority are fine with PRP, but there are some patients who are really reticent to do it because of the peripheral vision compromise. They want to retain all of their peripheral vision. They don't want to lose any of it. That the thought of that really bothers them. And so those are the protocol S type people who would, rather just have multiple anti-VEGF injections to try to regress their neovascularization than have a one-time PRP session. So it definitely, is worth the question, would supplementing with peripheral MicroPulse potentially increase the injection interval for people for whom you're treating proliferative retinopathy?
Totally agree. I think it's definitely something that's probably worth a little clinical series and bringing enough people together. I think it's a very, very interesting idea. So great point for sure. Another question from one of the attendees is, how do we know if the laser is actually taking, because it is sub-visible treatment endpoint? I think the panelists have spoken about that a little bit. Dr. Goldberg had mentioned about doing a titrated spot, not necessarily to see what the power is, just to make sure that your laser is working. So I do the exact same thing. I just throw on a laser just to make sure that, the staff haven't stepped on the fiber optic cable and now there's really not an adequate power coming into the eye. So that spot really is just to know what my power setting should be and to make sure that the laser is working. And then, yes, then a lot of it is faith. You just have to sort of believe that things are actually working the way that they are. It's somewhat unsettling, but then when the results come back, it becomes much more comfortable over time. All right, we are scheduled till 6, and these are some really, really fantastic questions. So if there are any other questions, we will hang out. Oh, it looks like there was just one more here. So what is the spot size you use? I personally use a 200 micron spot size. You guys as well?
I use 200 as well, yep. And I use a lens that doesn't magnify.
Perfect, yeah. I do the Centralis as well, that does have a slight magnification. I do like the wider field of view, just like Dr. Kavoussi. I also do think that the digital Volk series is just such a optically superior lens to the other lenses. And so it really does seem to work better, at least in my, maybe it's just that they've been not in a drawer for the last 6 years being scratched by my partners, but it seems to work better in my hands.
I think that is the answer. I carry my my Mainster focal lens with me. It doesn't get left.
Exactly. That's fantastic. All right.
So, the one other thing I just wanted to quickly mention, both of you guys kind of had mentioned COVID and about, hey, reducing the injection burden. It helps keep patients out of the office, helps keep vulnerable patients out of the office, helps keep the office from getting overcrowded. And I just think it's important to also just kind of quickly mention the corollary, though, which is, I have not been doing anything differently with our lenses in terms of the cleaning protocol on my lens. I think we were all concerned, especially initially, about potentially COVID spreading through the eye or through eye fluids. I do not. I put a proparacaine drop on the eye and then a little gonio in the lens. I do not put like a drop of betadine or chlorhexidine onto the ocular surface. I don't know if either of you guys do that. And I've just been washing my lens with soap and water. We did, just like we put on, frankly, all of our slit lamps, we put a kind of like a plastic shield at the level of the oculars, and that just does create a little bit of protection between the patient and the treating physician. Obviously, we're all still wearing masks. I'm vaccinated. Most of our patients are, but certainly not all of them. And so anyway, it had that side of it has not been a concern for me. Have you had any patients ask you guys about that or express concern in any way?
No, that hasn't come up for me, and I use the same cleaning protocol as you without any issues.
And me as well. That has not come up. Patients don't seem to have that concern, and the possibility of being able to come in fewer times is certainly more exciting to them than any concerns that they have sort of on the actual visit time. So it's a great point. Maybe it is something we think about if we're using a little drop of chlorhexidine on the ocular surface before we do the laser. That's a very interesting thought. It's kind of like giving betadine for pink eye. So perhaps we are being able to help that. So. Okay, so really quick, one last question. Any future prospective randomized clinical trials for MicroPulse laser? There are actually several that are happening. I will actually direct that to Joan Stauffer, who is listening in the background. She is kind of the medical guru for all things MicroPulse and is very aware of current clinical trials. I know that there at least was a clinical trial at UC Davis that was happening with patients with excellent vision in diabetic macular edema. So certainly are clinical trials that are currently happening right now. Okay, and one last question here about treating the polyp. So yes, I do it very similarly. So for polypoidal, and obviously with the Everest data, you do want to try and focus your PDT on the active leaking polyp. What I do is I treat everything, and that's really, I think, for me, a good strong point with MicroPulse laser treatment is it doesn't work like focal. You really want to treat not just the area of leakage, but really beyond it. And so I think that circle that I drew is really kind of telling for what I do. You really want to see where the areas of leakage are, but then you want to treat any areas of abnormal anatomy. So again, if you're finishing with fewer than 200, 300 spots, that's probably not enough. So I will treat the polyp, I will treat the area of leakage, and anything associated with potential RPE dysfunction. Great questions. All right, well, it has been an absolute pleasure. Thank you so much, Dr. Kavoussi and Dr. Goldberg, for your time. Again, I feel like I learned more from these sessions than anyone, and it's been an absolute pleasure having all the attendees join us. So if there are further questions, feel free to reach out to Iridex, and they can certainly get in touch with us for any last minute questions. So thank you everyone again for your time, and look forward to seeing you with you soon.